Next witness is Dr. Jane Orient. Dr. Orient has served as the Executive Director of the Association of American Physicians and Surgeons, AAPS, since 1989, and is currently President of Doctors for Disaster Preparedness. More than 200 of her papers and op-ed pieces have been published in the scientific and popular literature on a variety of subjects, including risk assessment, natural and technological hazards and non-hazards, and medical economics and ethics. She's the editor of AAPS News, the Doctors for Disaster Preparedness newsletter, Civil Defense Perspectives, and is the managing editor of the Journal of American Physicians and Surgeons. Dr. Orient obtained her undergraduate degrees in chemistry and mathematics from the University of Arizona in Tucson and her MD from Columbia University College of Physicians and Surgeons in 1974. Dr. Orient is formerly clinical faculty in the Department of Internal Medicine at the University of Arizona College of Medicine and has been in solo private practice of general internal medicine since 1981. Dr. Orient.
Thank you, Chairman Johnson and Ranking Member Peters and committee members for allowing me to present the plea of practicing physicians for early and prophylactic home treatment for COVID-19, and also thanks to the witnesses for the opportunity to learn from you. We urge the committee to exercise your oversight functions over federal agencies that are effectively blocking treatment that could prevent 100,000 needless deaths and stop the crippling fear and the destruction of millions of livelihoods. On August 18th, Senator Ron Johnson, Senator Mike Lee, and Senator Ted Cruz asked the FDA to provide any studies and data that informed the FDA's apparent determination that giving hydroxychloroquine to infected outpatients within 7 days from the onset of symptoms will have no clinical effect and may be harmful to the patient. FDA's tardy response provided no references pertaining to the question. The only logical conclusion is that the FDA's extremely influential determination that prevented treatment for untold thousands of patients was without foundation. FDA Commissioner Stephen Hahn has stated correctly that FDA has no authority to regulate the practice of medicine and that doctors have the right to prescribe approved drugs for off-label uses. But as AAPS has shown in its lawsuit against the FDA, state agencies have used the FDA's language as the basis of regulations to block or forbid the prescribing or dispensing of hydroxychloroquine. In March, HHS Secretary Azar asked BARDA for a nationwide expanded access investigational new drug protocol for hydroxychloroquine and chloroquine in the National Strategic Stockpile, but this would have legitimized these drugs for the treatment of COVID-19 outside a hospital. But instead, influential physicians or officials, non-physicians, transformed the request into an emergency use authorization only for hospitalized patients, to the patients who were the least likely to benefit. So instead of expanding access, the EUA restricted access. And later, FDA withdrew the EUA, further impeding its use, and the HHS is presumably still hoarding more than 50 million doses of hydroxychloroquine while people are complaining about a potential shortage. At its November meeting, the AMA refused to rescind its unprecedented statement calling for physicians to stop prescribing hydroxychloroquine until sufficient evidence becomes available to conclusively illustrate that benefit outweighs harm. Yet there have been 192 studies compiled on hydroxychloroquine, with all showing some benefit when used early, in contrast to the handful of studies on remdesivir or monoclonal antibodies, which are the only things that the NIH recommends. More than 65 years of experience and hundreds of millions of patients have demonstrated safety. Hydroxychloroquine is safer than most over-the-counter drugs, including acetaminophen. However, organized medicine and academic physicians such as Dr. Ashish Jha have stated that the evidence is insufficiently scientific, doesn't meet their gold standards of the randomized controlled trial. But the fact is that most of the guidelines that we use for most diseases have relied on lower orders of evidence necessarily. And studies with appropriately analyzed data give results identical to RCTs. And RCTs themselves are not infallible because they can be designed to succeed or designed to fail. Researchers in 2 hydroxychloroquine trials even used toxic or lethal doses of the drug, and then noticed that, yeah, it did harm. Publications in the most prestigious journals does not assure reliability. There were huge studies that were based on probably fabricated data with flaws that were undetected by the peer reviewers or the editors, rushed into publication and had to be retracted by Lancet and the New England Journal of Medicine, but not quickly enough to prevent their significant misleading and harmful effects. RCTs are useful for testing, but they're not for making discoveries, which are often serendipitous, like the use of ivermectin, for example, in nursing home patients with scabies. The smallpox vaccine was discovered because GPs were sharing observations, now we call them anecdotes, at the pub. They noticed that farmers who had had cowpox didn't seem to get smallpox. Or they may result from the study of basic science and observation on patients, like today's protocol for Wegener granulomatosis was based on a 1973 article of non-randomized patients, which was written by none other than Dr. Anthony Fauci. Today, we have top-down, authority-based standard of care for early COVID promulgated by NIH guidelines, which is therapeutic nihilism. We lately added the expensive, largely unavailable monoclonal antibodies, but other than that, before the patient's in the hospital and on oxygen, the NIH recommends nothing. This is shocking and unprecedented, but in today's litigious environment, doctors who follow this standard of care are protected, and those who dare prescribe outside of it could be fired, removed from their insurance panels, investigated, and even delicensed. Patients nationwide are calling us at AAPS searching for a doctor who will treat them. One patient told me he had had his wife drive him all the way to Dallas when all the doctors he knew in Tucson refused to prescribe for him, and his symptoms got better within hours of getting hydroxychloroquine from the doctor in Dallas. Doctors are reporting to us that they can't get hydroxychloroquine for their nursing home patients, and the family doctors even told us that infectious disease specialists have refused to treat COVID patients. We're relying on quarantines, masks, and lockdowns. These are not backed by RCTs. They have not stopped the pandemic. They're not sustainable. Vaccines are touted as the great hope, but we don't have them yet, and they have not yet been shown to prevent contagion. What we need now is effective early treatment for COVID-19. Hydroxychloroquine and other safe, long-used agents, such as ivermectin, is showing particular promise, but there are others. They could be immediately available if the government stopped blocking access and deterring their use. Physicians need to do as they've always done. They need to respond to the needs of their patients, use the best available information, share that information, and continuously strive to do better. Thank you so much for this opportunity.
Thank you, Dr. Orient.
The biggest stories the moment they happen from around the globe. Subscribe to Bloomberg Quicktake now for insight in an instant.